So I thought it's better to make it a case-based presentation rather than theory. So there is some inevitable theory which we'll talk about, but let's quickly look at what we've got. This is a 35-year-old male who comes with an anterolateral MI with moderate elbow dysfunction and cardiogenic shock, lies with reteplace outside and taken the next day in our lab. And this is what we get when you do the angiogram. He's got a thrombotic occlusion of the LAD with a large diagonal coming out from the same segment, and there is a large amount of thrombus there. Now he's got ongoing chest pain, so there's no option of taking him off the table. We have to do something with this, and whatever we do, you're going to end up with a problem with our conventional tools. So you can see that the thrombus burden is quite large, the vessel is badly diseased, and obviously there must be a large plaque rupture which has deformed the vessel and has formed a nidus for even larger thrombus burden. So we went ahead and did an ELCA laser-assisted PTCA to the LAD. For the sake of brevity, I'm just showing you the basic steps. So the most important thing is to go very, very, very slowly, increase to whatever fluence you want to, what you feel is suitable for that particular patient. We typically start with 40 or 60 and go to 80 in case our second pass at very, very slow speed has not cleared the thrombus adequately. This is what we got at the end. And everybody was happy and we left it alone. We've not done any intervention to this patient further beyond this. Then we brought him back to the table at the end of a month, and this is what we find. The vessel is flowing TIMI-3. There's obvious anatomical abnormality with a big rupture and a huge crater there, but we left it alone. And it shows you what can be done in case one is able to get rid of the thrombus in a complete fashion in patients who have got large thrombotic burdens with acute MIs. This is an 18-year-old girl, was healthy, presented with sudden chest pain and vomiting 2 days prior, came to us in shock on inotropes. Enzymes were elevated. She was already 2 days post. The echo was suggestive of an anterol MI with severe elbow dysfunction, cardiogenic shock, SCAI class C. So emergency bedside and IBP was inserted and a right heart cath was done. The PA sats were 36, which means she has hardly got any cardiac output at all. So this is what we did. We did a right heart cath quickly and then did an angiogram. And you can see that there isn't any LED visible. The first branch which is coming off, that's the ramus, or the first diagonal, looks like a ramus, is completely occluded. The RCA seems essentially free from disease. Now in this situation where you have absolutely no idea and she's living on just one vessel, it's important to get as much flow as possible into as much of the coronary tree as possible with as little embolization as possible. And that's what we started doing. So first we wired both and then used ELCA into the LAD with a 0.9 millimeter. This is our routine practice. And we finally finished with 24 cycles at 80-80. That's the maximum that we have. We were still reluctant to use contrast. Flow wasn't very good, but after that, we combined it with the plain balloon angioplasty with the 2.5 millimeter balloon into the LAD and the ramus, and then did good amount of thrombus aspiration. Intracoronary thrombolysis, because we still didn't get any satisfactory flow distally down the track, and then added some more balloon dilatation. In between, we went back in with the laser. For the sake of brevity, I'm not showing you all the steps. Into the diagonal and the LAD and the ramus, and did a POVA with the 3.5, and that's what we got finally. We left it at that because we felt that there was a large aneurysm. If one looks carefully, the place where the circle is, there's a large aneurysm there. She had a stormy course in hospital with an IBP plus heparin. She had some drop in hemoglobin that was corrected with some blood and triple therapy plus treatment for ADHF. She recovered gradually. And when we put her back onto the CT table at the end of a month, this is what we found. She had a huge irregular eccentric aneurysm in the proximal LAD that was 17 into 9.8 millimeters with a fusiform aneurysmal dilatation up to 10 millimeters. She was most likely Kawasaki's who came back with thrombotic occlusion of the proximal LAD, and she's been referred for a CABG thereafter. So in a young population, acute MI is a very, very challenging situation. Our patient had massive thrombus burden, and we used combination of all the therapies that were available to us. The order in which we use them is a matter of debate. We used ELCA because we felt that the embolization is inevitable if you instrument the vessel more. So you try and get as much of vaporization of thrombus as possible before inserting any other instrument into the coronary artery. Aneurysms are always difficult and they're not so easy to diagnose acutely when the vessel is filled with thrombus. This is a valuable tool in high thrombotic lesions. This is the third situation that I wanted to speak about. This is a 72-year-old patient who was post-CABG 12 years back, comes with ongoing chest pain or lateral wall MI on the ECG with ST elevation V4 to V6. And this is what his vein graft is like. This is a completely occluded vein graft before the wire goes in. Once we're able to wire it, we then use the laser to slowly vaporize the thrombus. And that's just a check shot to show where our occlusion is. We put in a distal protection device, deploy it, put in a stent, retrieve the filter, and that's what we get finally, and we back off with that. Now, laser has multiple mechanisms of action. A little bit of theory is inevitable. It has photochemical, photothermal, and photomechanical ways in which it actually destroys tissue. And the combination is best when we have a large thrombus burden, because you can actually vaporize it without embolizing a significant volume downstream and causing the inevitable slow flow that will occur in case we place any instrument down the coronary tree. The molecular bonds broken, the duration of the laser pulse hits tissue for 135 billionths of a second, and billions of molecular bonds are fractured per pulse. The absorption vibrates, heats the intracellular water with the vibration, the water vaporizes, breaks the molecules apart, and cells rupture. And this expanding vapor bubble forms in 100 millionths of a second, 1,000 times the duration of the actual laser energy emission. This creates kinetic energy, and the expansion and collapse of the vapor bubble actually breaks down tissue and clears the byproducts away from the tip. These byproducts are water, gas, and small particles, and the entire process is complete in 400 billionths of a second. That is 4,000 times the duration of the actual laser emission. Thrombus in critical locations, that is the left main and the ostial proximal LED. Thrombus in very, very high volumes when the entire vessel is choked with thrombus. Thrombus in saphenous vein grafts which are old and degenerated. These are situations where the laser technology is invaluable. These situations are difficult to manage with conventional tools. Laser offers the opportunity to vaporize with minimal embolization. This is a point which cannot be stressed enough, as all interventional cardiologists will agree. This adds safety and efficacy to primary PCI. In a Japanese center who's been using laser from 2016, whose primary operators I was privileged enough to speak to, they say that it reduces the thrombus burden by about 35%, and they always combine it with mechanical or aspiration thrombectomy, which reduces by 40%. Their order is the same, except in case it is downstream, in which case they will use the mechanical thrombectomy first or the manual aspiration first and then the laser. And especially in young population with little atherosclerosis and very large thrombus burden, this is one of the tools that can deliver an excellent result in these situations. Thank you for your attention, and I should be glad to answer any questions.